Thank you so much for listening to American Medicine Today. I'm Kimberly Bonatti, joined by my friends Ethan Euchre.
Happy to be here.
Yes, Jeff Wagstaff.
Hello, everyone.
Hello, and world-renowned orthopedic surgeon, Dr. Alfred Bonatti.
I'm happy to.
So, Dr. Bonatti, we're going to be talking about patient safety concerns and diagnostic errors, correct?
In the last month was an organization that's trying to discover by scientific research what is happening on the diagnostic errors. And one of the things that they start is to see which medical devices can be the best, what medical procedures can be the best, what drugs, and how to improve the patient care with all these different elements that they are studying.
Okay.
Well, and the major concern is that there are errors on the diagnosis.
Why is that?
From every 20 people that they go to be in some
Diagnosed.
sort of healthcare,
Sure.
the diagnosis fails in one.
One
so
of 20?
It's a mistake.
One in
One
20.
in every 20. Millions of people that they are being seen daily.
Okay.
And if you have one in every 20, it's a massive amount of mistakes on the diagnosis.
And what do they say is the cause
Well,
of these errors?
there are things that they are trying to look together with the diagnosis. One
Sure.
is the opioid therapy. The other one is the care of the setting where the patient's being treated.
Okay.
Other one is emergencies, readiness in case of the patient arrives to emergency room, and the device properly disinfected or sterilized.
Sure.
All these things can create a situation where you compromise the diagnosis of the patient.
Right.
The technology today is so advanced that when the people order tests, sometimes you can order a test that is wrong at the wrong time.
Okay.
Another time you can order a test and the test is at the right time, but it's a wrong test. Other time you can order the test that is at the right time, is the right test, but the specimen is obtained in the wrong area.
Okay. What does this particular institute think that needs to happen for those things to be rectified?
Well, what they're thinking, the best idea is to create an algorithm.
Okay.
And then that will practically supplement the diagnosis knowledge of the physician and will bring some other types of diagnosis that they are obscure or forgotten or poorly trained.
Sure.
So this algorithm will remind the physician, remember this. The problem with this is like everything that is technology is going to be so broadly expanded that suddenly you can have millions of diagnoses in something that is very simple.
All right.
So the algorithm is a good idea, but the way that they are trying to apply it is a horrible idea.
Okay.
Because what they are going to do is they're going to bring illnesses that they happen in very underdeveloped countries, and it's going to be a priority that you need to investigate that because it's part of those symptoms.
Am I correct in thinking your logic is if they bring in socialized medicine, we're going to get away from true MDs or doctors treating patients, and we're going to have lesser care because now we just have healthcare providers, be it nurse practitioners, physicians' assistants. Is that kind of where you're going with this?
The idea of an algorithm is to replace the human and put the machine to do the diagnosis. And the interpretation of that diagnosis is going to create a massive amount of testing. So the expenses are going to be brutal.
Right.
Okay, so if they want to do something like that, they need to do an algorithm for a specific type of a problem and then allow that problem to be worked. For example, if you are an internal medical physician, only directed to the internal medicine doctors that they can work on that small part of the algorithm.
Okay.
But if you suddenly get to an internal medicine doctor then
it's going to
you
work like a
with that.
specialist.
Yeah. And then suddenly you have this algorithm that's going to ask you for illnesses that happen
Sure.
in the Congo.
Got
okay?
it. Right.
And then you have no choice because they are going to force you to utilize that and use tests to prove that you don't have that disease.
Sure.
And then you're in the United States. You're not going to get that disease. Okay?
Correct. And we've also seen, though, because they have placed nurse practitioners in place of doctors, certain tests are being run when they don't need to be. The opioid epidemic is actually worse. So there's many concerns.
Every time that you try to replace an MD who has a tremendous amount of hours of learning,
200,000 hours versus 50,000.
exactly. Yes. So when you have that type of a difference, and you try to replace that, you're going to have a gap, and that gap is going to be in practically non-service to the patient.
It's a very important topic being covered on American Medicine Today. Make sure you check us out again next week.